Dr. Susan Gould from Internal Medicine and the Center for Bioethics and Social Sciences in Medicine is going to introduce our speakers, and will also introduce several of the Bishop family members who are joining us today. So I would like to turn it over to Susan Gould.
Well, actually, before I introduce our speakers or whatever, Christine Bishop, one of the at least 3 or 4 members of the Bishop family here today, I don't know if I've seen all of them, I would like to say a few words about the family.
I'd just like to say a very brief message from all of our family, how very pleased we are about how my parents' generosity has been carried out by you folks here with this wonderful lecture, which seems to add a little extra spark to a wonderful day. We're just fascinated by these different talks today. So on behalf of my brother David, who is here, my brother Andrew, my sister Ellen, we're just delighted with all of this. And my dad's little sister, Aunt Jane, is here also, and some of my parents' colleagues. The choice today is just wonderful. As an economist, I always have tried to bring to healthcare the idea of the informed consumer. And Dr. Groopman and his work have really brought that together. My father always was an advocate for patients and their informed decisions. But I think what I wanted to say most of all was my mother was a New York girl, and she came out here to the wilds of Michigan and brought up 4 kids and probably felt a little isolated and out in the country and out in the Midwest. And about once a month, her parents back in Brooklyn bundled together their copies of the New Yorker and sent it to her. This is back in the 50s, before the New Yorker was a nationwide magazine. So I think what would thrill her most of all was to have someone who writes so beautifully for the New Yorker giving the Bishop lecture.
Thank you, Christine. That was just wonderful. The personal touch is great. I want to welcome everyone to the Ronald C. and Nancy V. Bishop Lecture in Bioethics, and a special welcome to the many family and friends of the bishops who are here. I'm Susan Gould, as Nancy said, and I had the distinct honor and pleasure of knowing Ronald Bishop, who attended a monthly discussion seminar that I led when I first got here many moons ago. And he and his wife, Nancy, both graduated from the University of Michigan Medical School, by the way, in 1944. They married a year later and raised 4 children in the area. And Ron joined the faculty in, I think it was 51, and remained here until his retirement. So this lecture series results from the generosity of the bishops, Ronald, Nancy, but also their children. And I am delighted to welcome a pair of speakers, a pair of wonderful speakers this year, Jerome Groopman and Pamela Hartzband. And they are co-authors of Your Medical Mind, which I highly recommend, and was, in fact, on the break recommending a particular chapter to someone who was talking about end-of-life decision-making stuff. So I very much enjoyed your chapter in that way, in that area especially. So Dr. Groopman is professor of medicine at Harvard. He earned his bachelor's from Columbia College and then graduated from Columbia College of Physicians and Surgeons as a valedictorian. He completed an internship and a medical residency at Massachusetts General Hospital, a fellowship in hematology oncology at UCLA, and a research fellowship then at Boston Children's and Sidney Farber Cancer Center. His awards are, as they say in pathology, too numerous to count. But here are a few highlights. He won the Best Wellness Book in 1997 and 2004 and 2007. The American Medical Writers Association presented him with an award for excellence in medical communication in 1998, then presented him with a John McGovern Medal for preeminent contributions to medical communications in 2003. And in 2008 and 2009, he was named a Knowles Scholar at Harvard for recognition of his undergraduate teaching. He's got even more publications and many, many books. And this is the part where you wave around the book, which the Kindle has changed all that. So I'm going to wave around my Kindle. If you want to see the titles, I can show you later. But the other thing about his publications is that very notable for their variety. For instance, one recent publication, I'm going to try with this one. In the British Journal of Pharmacology, endocannabinoid-like and arachidonal serine is a novel pro-angiogenic mediator. This is not the topic of the talk today. Easier to pronounce, a recent piece in the New England Journal, The New Language of Medicine, which was written with co-author Hartzband over there. So Dr. Hartzband's career has taken her to many of the same places with some overlapping directions. She earned her bachelor's magna cum laude from Harvard, graduated from Harvard Medical School, completed internship and 1 year of medical residency at Mass General, and then finished her residency at UCLA. After a stint as chief medical resident in Massachusetts, she completed a fellowship in endocrinology at UCLA again. She's currently an assistant professor of medicine at Harvard, a fellow of the American College of Physicians, and a member of the Council of Medical Society's Patient-Centered Medical Home Working Group. Very hot topic these days, and one I'm sure benefits a great deal from her insights. She has a profound teaching record, pages and pages of residents, fellows, and students who she has mentored over the years and has had leadership roles in medical curricula. Both of them received the Humanism in Medicine Award from the Arnold Gold Foundation last year. I know there's much wisdom we can learn from these two, and I welcome them today to present When Experts Disagree, the Art of Medical Decision-Making. Thank you.
Well, we'd like to thank the Center for Bioethics and Social Sciences in Medicine and the Bishop family for inviting us here to talk about medical decision-making. And we're especially honored to present the, what I understand is the second annual Bishop Lecture in Bioethics. So we're going to plan to talk for about 45 minutes, and then we'd like to take your questions and comments. We're really interested in hearing from all of you. As doctors, Jerry and I spend a lot of time working to stay up to date on the latest developments in medicine, and in particular to sort through the controversies where the experts disagree about testing and treatment. And today, we hope to convince you that when you understand why the experts disagree, that you'll be able to make better medical decisions. This is our disclosure statement. As you heard, we're the co-authors of Your Medical Mind, How to Decide What is Right for You. So in recent years, there's been a shift. It's not just medical professionals who are struggling with these issues. All of us are now directly confronted with medical information and advice through the media. You can't pick up a magazine or a newspaper, turn on the television or the radio, and certainly you can't go on the internet without getting medical advice. And because of this, patients are increasingly aware of the existence of controversies in medicine, the areas where the experts disagree. So I'm going to show you some examples in the next few slides. And this first slide, I took this picture with my brand new iPhone. It's from the Wall Street Journal in January, and it highlights the controversy about whether otherwise healthy people with elevated cholesterol should be treated with statins as a prevention for heart disease. So on the left, you see, yes, they save lives, and on the right, no, high cost, little gain. Another controversy that's been in the news recently centers on vitamin D. Should everyone be taking vitamin D, and if so, how much? What's the normal level of vitamin D, and should we even be measuring levels? So this slide shows the headlines from November 30th, which was when the Institute of Medicine issued their report on vitamin D. And you can see that the headlines are conflicting. On the left, the New York Times reads the report and says, extra vitamin D not necessary. And on the other side, the Wall Street Journal says triple your vitamin D intake. So this certainly added to the confusion. I'm sure you're all well aware of the controversies about mammography and cancer screening for men for prostate cancer. So this slide is from a piece in the New York Times in October, where at the bottom you can see it says, has the power of the mammogram been oversold? Questioning exactly what age a woman should begin to have a mammogram and how often mammograms should be done. Should a healthy man have PSA screening, and if prostate cancer is diagnosed, how should he be treated? So this is from the PBS NewsHour, again in October. It was a special broadcast highlighting the debate about PSA screening and treatment of prostate cancer. So every one of these issues, and many more, remain an active controversy, debated both in the medical literature and also in the lay press. So with this flood of information, the public has become acutely aware that experts disagree. So how does a patient make a decision in the face of all this controversy and conflicting advice? We didn't have a ready answer, so we began to search.
So first, we went back to the textbooks, and we looked at classic medical decision analysis, which is drawn from economics. And a formula is used to calculate the, quote, best decision. And this formula was derived by Daniel Bernoulli, who was a mathematician in the 1700s. And Bernoulli was looking at decision-making in the marketplace. And he said that the best choice is calculated by looking at the probability of a certain outcome and then multiplying it by the utility or the impact that that outcome has. Now, in economics, the probability of an outcome might mean the chance of achieving a certain market share or selling a certain number of products. And the utility is basically the profit in dollars, and more specifically, the impact on the bottom line. And this formula underlies much of economic decision analysis. Now, it has been imported into medicine. And when applied to medicine, you can estimate the probability of an outcome. For example, in considering treatment of prostate cancer, you can look at the probability of the outcome of a side effect, such as incontinence or impotence after surgery. But then the question becomes, how do you put a number on the second part of the equation, the utility, the impact it has on your life? Now, there are three different methods that have been used in classic medical decision analysis. And the first is a linear rating scale from 0 to 1, where 0 is death and 1 is, quote, perfect health. And you're supposed to look at the scale and say, well, if I had urinary incontinence, or if I were sexually impotent, my life would be at this point on the scale between 0 and 1. Another method is called a time trade-off. And this is how many years of your life would you be willing to trade off or give up in order to avoid incontinence or impotence. And the third comes from game theory, and it's called the standard gamble. And here you're asked to imagine that there's a magic pill. And this magic pill can completely prevent a certain outcome, such as incontinence or impotence, but in a certain percentage of cases, it causes instant death. And you're supposed to estimate what odds you would be willing to take to completely avoid a certain outcome versus the chance that it might kill you right off the bat. Now, recent research in cognitive psychology has shown that all three of these methods are severely flawed. The problem is you can't reliably forecast your life in the future. You can't accurately understand the impact that a certain outcome will have if you've never experienced it. Also, as you know, medical conditions are not static. They're dynamic, and people adapt. So the impact that a condition is having on your life changes over time. Despite this, These three methods are very well established and broadly used in deciding what is best in medicine. They are used in calculating so-called QALYs, quality-adjusted life years. They are the underpinnings of government priorities in the United Kingdom through the National Institute of Comparative Effectiveness, NICE, where they asked 3,000 healthy British citizens how much time would you trade off, for example, to avoid incontinence or impotence or any other medical condition. And in the United States, they are used by policy analysts and insurance companies. And recently they were proposed in an article in the Annals of Internal Medicine to be the basis for cost-effectiveness priorities in the United States as part of healthcare reform. Now, what happens when you ask people who actually have the medical condition? Well, and it turns out that self-reported quality of life from patients is very different from what we imagine as their quality of life. For example, in Britain, they'll ask healthy citizens, if you were blind, what would be the impact on your life? And on the linear scale, it comes out to 0.5. It reduces the utility of your life by 50%. Now, I happen to have a first cousin who's been blind since birth. She was born prematurely. She was exposed to oxygen in those days. She worked her whole life as a teacher for the blind. She speaks 4 languages. She's currently retired. She's active in her synagogue. She volunteers in an assisted living facility where she helps sight-impaired elderly people access the computer using Braille keyboards. If you told my first cousin that her life was a 0.5 on a scale of 0 to 1, she would slug you. Now, similarly, men diagnosed with prostate cancer, if you look at a group that chooses so-called active surveillance, watchful waiting, no intervention, no surgery, no radiation, versus a group that has prostatectomy, that has surgery, and then has a very high rate of incontinence and impotence, both groups report the quality of their life at the same level. So in fact, when you speak to people who actually have a certain medical condition, their assessment of their own life is very, very different from what people who are healthy or have never experienced the condition believe. So this entire structure of decision-making is deeply flawed. And in fact, Daniel Kahneman, the Nobel laureate in economics, who's a cognitive scientist, recently gave an address to an international meeting of medical decision analysis. And he said this paradigm of measuring utility is like measuring the ether in 19th century physics when the ether did not exist.
So we realized the textbooks were not giving us the answers that we were looking for. And then we thought about William Osler, one of the most famous physicians of all times who practiced in the late 1800s and early 1900s. And he was famous for many things, but among them a very famous comment about how to make a very difficult medical diagnosis. And he said, listen to the patient, because if you know how to listen, he's telling you the answer. So we decided to listen to patients. We interviewed scores of patients in great depth. Patients of different ages, different parts of the country, different socioeconomic backgrounds, and different kinds of medical problems. And we asked them how they made their medical decisions. And although we found that patients were individual in how they made their choices, there were common threads that they took in their approaches to their health and their medical problems. And to explain these common threads, we'd like to involve all of you right now in a thought experiment. So we'll begin just by asking you a few questions. I'd like you to raise your hand if you've been a patient yourself over the past year, and by patient, I mean obviously a visit to the hospital or the emergency room, but even just a checkup or a minor issue where you saw a doctor in an office. So raise your hand. So pretty much everybody. Okay. So now try to remember that experience of being a patient. Put yourself into the mindset of being a patient, and now imagine that you are sitting in your doctor's office and your doctor tells you that your blood pressure is too high and that you've already tried exercising, you've changed your diet, you cut out salt, you lost weight, and still your blood pressure is too high. And your doctor says, okay, now we need to begin medication. So raise your hand if you want to be proactive. You want to aim for perfect blood pressure control, and you'll do whatever it takes to get that. Okay? Now raise your hand if you feel that your blood pressure doesn't have to be absolutely perfect. You just want the minimum amount of medication. So the term we apply to the first group, you're the maximalists. You want to be ahead of the curve, do everything and more. The second group, you're the minimalists, less is more.
Okay, so your doctor prescribes a blood pressure medication. It turns out the medication comes in two forms. One is extracted from an herb, a natural source. The other is made in a laboratory using the latest technology. Both are chemically identical and cost the same. Your doctor offers you a choice. Raise your hand if you would prefer a medication derived from a natural source. Okay? Raise your hand if you prefer a medication made in a laboratory using the latest technology. Okay. Now, people who raise their hand first have what's called a naturalism orientation. When they're initially considering a therapy, they look to a natural source, whether it be supplements, herbs, acupuncture, massage, for a problem that may potentially be amenable to that. And about 60% of the United States has a naturalism orientation in surveys. The second group has what we call a technology orientation. These are people who look to the latest, greatest high-tech breakthrough, the cutting-edge treatments.
So now your doctor gives you a prescription for the medication that you chose, and you fill the prescription, and now you're just about to take the first pill. So raise your hand if you swallow it down, confident that you're on the right path to solving your problem of high blood pressure. Now raise your hand if you take the pill out of the bottle, stare at it for a while, read the side effects a few more times, and then wonder if you should really take it. So the first group, you're the believers. You're certain there's a good solution for your problem, and when you find it, you'll go for it. The doubters worry that the treatment will be worse than the disease. So the terms for these mindsets are these are the common threads that came out of the interviews that we did with patients. And these mindsets applied not only to problems like high blood pressure or high cholesterol, but also to decisions around surgery and treatment of very serious illness like cancer.
So one of the first patients we spoke with is a woman we call Susan Powell. All the people we talk about are real, but we changed their names for confidentiality. And Susan is in her 40s. She lives in Boston. She works as a nurse's assistant. And on a routine checkup with her primary care doctor, she was found to have an elevated cholesterol level of 240. And this was confirmed, and the normal cutoff is now 200. Now, Susan's an active person. She walks regularly, follows a healthy diet, is not a smoker, doesn't have hypertension or diabetes. And her doctor said to her, Susan, you need treatment for your high cholesterol. You need a statin medication. This will decrease your risk of a heart attack by 30%. Now, that made an impression on Susan. She said she'd think about it, but she did not immediately fill the prescription. And over the course of a few months, she sought more information about elevated cholesterol and its therapy. And while surfing the internet, she came upon a government website that has what's called a risk calculator. And here you put your individual characteristics in. In her case, her cholesterol level, her age, her gender, the fact she's not a smoker, doesn't have hypertension, and so on. And the risk calculator answers a key question that every patient should ask himself or herself regardless of their condition. And that is, what is the risk of a certain outcome without any treatment? Now, for a woman like Susan, in her 40s, with a cholesterol level of 240 and no other risk factors, the chance that she would have a non-fatal heart attack in the ensuing 10 years is 1 in 100, 1%. Even if she were in her 50s and her cholesterol had risen to 280, her risk of a non-fatal heart attack in the next 10 years would be 2%, 2 in 100. So you see how your mind plays a trick on you. When you hear that a statin medication will reduce your risk of a heart attack by 30%, it sounds as though you're at 100% risk for a heart attack. But in Susan's case, it's actually 30% of 1%. Or if she were in her 50s with a cholesterol that was even higher of 280, it would be 30% of 2%, which clearly has a very different impact in terms of thinking than what she had originally heard. Now, we spoke with some patients, like a woman we call Michelle Bird, who is a maximalist and a believer. And Michelle told us that she would immediately take a statin medication because she said, I could be that 1 in 100 who would have the heart attack over the next 10 years. I'm taking the drug. But Susan was a minimalist and a doubter and was not convinced by these numbers.
But there's more to Susan's story than numbers. Shortly after she was given the statin prescription, she went to a church dinner, and there she met an acquaintance who was hobbling around in obvious pain and looking very ill. And it turned out that this woman had been prescribed the very same statin medication that had been prescribed for Susan. And she had had a side effect, the most common side effect, myopathy or muscle pain. So as you know, stories like this have powerful effects on all of us. Cognitive scientists call the effect of stories availability because the powerful story stays in your mind and is readily available. These kinds of stories leave patients, indeed all of us, to overestimate the likelihood or probability of the similar event happening to us. So although stories can sometimes be helpful, they can also be misleading, making something rare appear common. Now, when you hear a story like this, you need to go back to the numbers. How common is this side effect of myopathy while taking a statin? Well, it turns out that the number ranges from as low as 1% to as high as about 10%, depending on the type of statin, the dose, other medications that you might be taking, and other medical problems. So 10%, that might sound like a pretty high number. But now let's present or frame the information in the opposite way. Between 90 and 99% of patients will not have this side effect. So this sounds a lot better, although the information is just the same. So when you're trying to make a decision or helping a patient make a decision, it's important to flip the frame and present or consider the information in both the positive and the negative. You might think that framing is primarily a problem for patients, but a recent Swiss study showed that physicians are just as susceptible to framing as patients are. So how do patients get numbers and other information about medical treatments? Well, one way is through drug advertisements. And it turns out that if you watch the evening news and about 2 hours of primetime television, you will see in excess of 1,000 drug advertisements over the course of a year, which works out to about 16 hours, and that's a lot more time than most people spend with their doctors. And these ads are effective. For every $1,000 that's spent, 24 new prescriptions are written. Now, drug ads are carefully constructed to use both the power of numbers and the power of stories to sell the product. So let's look at how it's done. Numbers are framed in the most positive way. For example, for a statin, the ad might say that there's a 30% decrease in the risk of heart attack, but obviously it's not going to say it's 30% of 1% or 2%, as Jerry just discussed. So now let's look at an ad for a new medication that was recently approved to treat patients with atrial fibrillation. The medication is dabigatran, and it's sold under the trade name of Pradaxa. And you may have seen these ads. They're pretty much everywhere right now. And this ad we took off an internet site, which was meant for patients. And the ad uses numbers very effectively. Shows a doctor, a cardiologist, who's presenting the information to the patient, and he gets your attention immediately by stating that if you have atrial fibrillation, you are 5 times more likely to have a stroke. 5 times. Now that sounds very threatening, and I think clearly implies that you need to be treated. So what are the real numbers? What's the baseline risk for stroke for atrial fibrillation if you're not treated? Well, the doctors in the audience here know that that depends on what's called a CHAD score, whether or not you have other medical conditions like heart failure, high blood pressure, diabetes, your age, and whether or not you've had a stroke or a TIA before. And the number varies between 0.5% at the lower end up to about 6% per year at the upper end for ambulatory patients. So 0.5 to 6%, these are much less impressive sounding numbers than 5 times increased risk of stroke. And now let's frame the numbers in the opposite way. So between 94 and 99.5% of patients will not have a stroke each year despite having untreated atrial fibrillation. Now the ad goes on to say that the risk for stroke associated with atrial fibrillation is decreased by 35% more with this new treatment than with the traditional treatment, warfarin. And this sounds very impressive too. But again, what are the actual numbers? So in the RELY trial, which was the trial used to approve this drug, the risk of stroke was 1.7% per year with warfarin and 1.1% with dabigatran, the new treatment, a difference of 0.6%. So although the relative decrease was 35%, the actual decrease was 0.6%, 0.6%. The information is the same, but presented in a different way. And I think you'll all agree that if we reconfigured this advertisement to say that it was 0.6% better than new medicine, I think you'd be a lot less impressed than 35%. So it's really important to be alert and careful when hearing relative numbers rather than absolute numbers. It turns out when patients hear the kind of information that's presented in drug advertisements, a study from Dartmouth showed that they generally think that the medication is 10 times more effective than it really is. Now, we've talked about numbers. How about stories? So if you've seen these Pradaxa ads, they're on television all the time, and one of them that caught our attention was one where a grandfather and a father and a son are all going off to fish. The grandfather's going to teach the grandson to fish on this lovely summer day. And the clear message is that the grandfather has made it in good health to this happy day because he's been taking this medication. And so the advertisers know that the story is powerful, so they keep the story going. And now the rest of the family arrives, everyone's hugging and kissing, the sun is sparkling on the water, and that's when the voiceover gives you the side effects. Serious bleeding, death. And they don't mention that there's currently no way to reverse the anticoagulation effect of this new medication if bleeding does occur, and they don't comment on the possible increased risk of heart attack with the new medication as well.
So experts are another source of information for patients. And this is, insurance companies have been advertising, saying that they have the experts. And you may have seen this ad from United Healthcare, which is a nationwide huge insurance company. And it tells the story of a woman who needs knee surgery. She's an active runner, very healthy, and so on, and had a knee operation in the past, and now she has more knee pain and needs an operation. And the insurer uses the mantra, health in numbers, and says that it has the experts who look at the numbers and generate report cards on doctors, specifically surgeons. And it promises the patient the following. You will know you get the right doctor. You will know you'll get the right procedure, and you will have the right outcome. Now, this is a false promise. I can tell you from my back surgery, it is a false promise. All right? The guy said, you'll be playing football in 2 months. I said, I never played football. It's impossible to promise anyone with any particular treatment, whether it be surgery or medication or whatever, that they will have the right outcome, meaning absolute benefit with no complications or risk. Now, patients also receive guidance from so-called expert committees. And as Pam said at the beginning of the talk, patients have become aware of the controversies and that there are different expert opinions. For example, cancer screening. 2 years ago, there was a major controversy over mammograms that continues to this date. And in a recent review in the New England Journal of Medicine, looking at the recommendations and the data, 4 different expert committees come out with 4 different recommendations with regard to when should a woman begin to have a mammogram, what age, and how often. The controversy over PSA screening pivots on 2 randomized controlled trials, also in the New England Journal in 2009. Now, there was a trial in the United States, and the American trial had a PSA screen group and a control group. Now, you would imagine that the control group would not have PSA screening. But it turns out that in the American study, the controls were assigned to, quote, usual care. And more than half of the men in the control group had PSA screening. So the American study showed no benefit in terms of reducing mortality, looking at this PSA screen group versus the control group. Now, a large multi-center study in Europe did show a benefit, but it also was significantly flawed in that there was no uniform cutoff for PSA about when to biopsy from center to center within the European consortium, and there was no agreement about how often to do PSA testing over the course of the trial. Now, an independent group in Gothenburg, Sweden, did a very rigorous trial where half the men had PSA screening, it was about 12,000 men, the other half, 97%, did not get screened. And there was a very significant reduction in mortality, a 50% relative risk reduction, but in terms of absolute, it meant that for every 12 men who were diagnosed and treated for prostate cancer, 1 life was saved, which in cancer treatment is actually a pretty high number. So you have 3 different expert committees. You have a government panel, the United States Preventative Services Task Force, the American Cancer Society, and the American Urological Association. And each one came up with a different opinion based on these studies, ranging from no screening at all for healthy men for the government panel, to an individual decision made between doctor and patient for the American Cancer Society, to recommending screening from the American Urological Association with shared decision-making. 3 different committees, 3 different opinions.
So now we want to get a little personal and talk about our own medical minds or mindsets. And Jerry, you go first.
Okay. So I was raised in a family with a strong Eastern European Jewish tradition where doctors were on a pedestal. Physicians like Jonas Salk and Albert Sabin were heroes for their work with polio and honored in the same way that Franklin Roosevelt and Winston Churchill were in defeating the Nazis. Science and technology were greatly honored as well. And anything that was thought to be natural was seen as a throwback to ignorant village life in Eastern Europe. So I was clearly raised as a believer with a very strong technology orientation. And being a believer meant doing everything to the maximum. In those days in my family, the attitude was every medication, every pill, every intervention had to mean better health. And my father, in his early 50s, had a massive heart attack and died. Now, he may have died because he did not get intensive, cutting-edge treatment and possibly could have survived if he had. Now, he may not have, but he did not get intensive therapy. So this reinforced my belief in intensive interventions. And that maximalist mindset extended not only to heart disease, but basically to all of medicine. So in the early 1970s, in my medical training, when I decided to become a hematologist and an oncologist, bone marrow transplant was coming to the fore, and at UCLA, there were patients with otherwise fatal leukemia who now, through this most intensive therapy, could be saved with a transplant. So this, again, cemented my mind as a believer with a maximalist and technology orientation.
And I had a different kind of upbringing. I was the first child in my family, and when I was a baby, the doctor told my parents that the new scientific way to feed a baby was to feed every 4 hours by the clock. So my dad, who was an engineer, was very enthusiastic about applying scientific principles to child rearing, and he made a chart for my mother every 4 hours so she could check off when she fed the baby, and then he went to work. And my mother, an artist and freethinker, did not have a very good day, hearing a lot of screaming, and finally took matters into her own hand and tried to feed me when she thought I was hungry. When my dad came home, he said to her, "How can you not follow the advice of the doctors, the experts?" And her response was, "Doctors don't know everything." My parents were ahead of the time with respect to a healthy lifestyle. They never smoked. They were avid exercisers. My dad woke us, my sisters and I, up early every morning to do the Royal Canadian Air Force exercises with him. And my mother had us eating whole wheat bread, which in the 50s was not a very tasty item, and we weren't allowed to have soda or candy. And my parents have had the good fortune, by virtue of genetics or their lifestyle, to live long and healthy lives with a minimum of medical intervention. My dad's 88. He still goes to the gym and works out for an hour every day, runs every day, and my mom is an avid golfer. And this background has contributed to my minimalist doubter orientation. So Jerry's a maximalist and a believer, and I'm a minimalist and a doubter. And we maintain these mindsets about our own health despite going to very similar medical schools and training at the very same hospital in Boston. So why are we telling you this? We're pointing it out to show you that doctors and experts have medical minds or medical mindsets too, and this can impact the advice that they give. So how might this play out in a clinical setting? Well, it turns out, and I probably don't need to tell this audience, that there are many parts of medicine that fall into a gray zone where there's not a clear right answer for everyone. And I'll give you an example from my own practice. As an endocrinologist, I frequently see patients with thyroid nodules, lumps in their thyroid. Now, the vast majority of these are benign, but a few turn out to be malignant. So to evaluate these, we do needle biopsies. Sometimes, even after several biopsies, we can't get enough cells to get a definite answer. And then we need to decide if the patient should have surgery to take it out or not. So recently I saw a patient in just this kind of situation. 3 biopsies were done, and there were not enough cells to make a definite diagnosis. The ultrasound showed no particularly worrisome findings, and the risk of malignancy in this setting is somewhere between 2 and 12%. So the patient said to me, "What would you do? What would I do?" So that's a question we get all the time as doctors. What would you do? What would you do for your mother? What would you do for your sister? So I said, if it were me, I'd watch and wait. But if it were my husband, Jerry, he would have had surgery yesterday. Different medical mindsets. So we're not suggesting that the doctor and the patient need to have the same medical mindset, but sometimes being challenged can help you to make a better decision. But the doctor needs to understand and respect the patient's mind, and the patient needs to be aware that the doctor also has a mindset. So now let's return to the subject of the experts and why they disagree. We believe that they disagree because they have different mindsets. So with regard to PSA screening, Jerry just talked about this. The United States Preventative Services Task Force, who recommended no screening for healthy men, that represents the minimalist doubter point of view. Less is more. And this has become an increasingly popular point of view with the rising cost of health care. The American Urologic Association, that represents the maximalist believer point of view. And the American Cancer Society, they fall in the middle. None of the recommendations are strictly objective. Everyone's looking at the very same data, but they value the information differently due to different mindsets.
Now, some of the most difficult decisions are made regarding end-of-life care. And many people believe that advance directives just take care of everything. But studies show that 50% or more of people change their minds. They choose differently when they're sick compared to what they wrote in their living will or advance directive when they were healthy sitting in their attorney's office. And this, again, is because you cannot forecast how you will think, how you will weigh risk and benefit in the future under circumstances that you've not yet experienced. Furthermore, advance directives cannot encompass every possible scenario. For example, a person may say, I don't want to be placed on a ventilator after receiving a diagnosis of lung cancer. But let's say that man develops pneumonia, and he needs to be on a ventilator for just a few days as the antibiotic treatment takes effect. And then he could live 1 to 2 years. Should he not go on the ventilator? Now, this is also linked to the issue of what is futile. When does it no longer make sense to give treatment from a clinical point of view? And experts have tried to develop formulas to calculate what is futile. And actually, Ralph Stern sent us a paper in advance of our visit which echoes this. And it turns out that these formulas have all failed because in the real world of patient care, you cannot identify that individual who will survive and go on and live. And in the studies that have tested these formulas, the individuals who go on and live often live very good quality of life for very long periods of time. And then surrogates. Now, surrogates are often called upon to make difficult decisions because the patient is not capable of thinking and choosing for himself or herself. Now, this is one of the most challenging and complex scenarios that we face in terms of both ethics and decision making. And there is no glib or easy answer. But we believe that it can be very helpful to go back to the mindset that we proposed, and that is to consider whether the patient who is incapacitated was a maximalist or a minimalist, a believer or a doubter, had a naturalism or a technology orientation. And then the surrogate can use that knowledge to try to inform a choice on behalf of the loved one or other person. Now let's return to how can a patient as an individual make a decision when the experts disagree. We think it's essential to assess 3 dimensions, and they're shown here. First is the patient's medical mind or mindset. Believer, doubter, maximalist, minimalist, technology, or naturalism orientation. That's simply the starting point. That's the beginning. Then you look at the numbers and try as best as you can to see how the numbers apply or do not apply to that individual. And finally, stories. Now, in terms of evidence-based medicine, scientific thinking, we often dismiss stories as mere anecdotes. But it turns out that research done by Daniel Gilbert, who's a psychologist at Harvard, and others, published in the journal Science, which is a pretty good journal, in terms of how to better estimate the impact of a certain outcome on your life. That second part of the Bernoulli equation, the utility, is best done by talking to someone, interacting with someone who has had the outcome, particularly someone who is similar to you in background, and then you try to get your arms around his or her own experience with a certain condition. And it's, of course, good to talk to more than one person, one who's had a good outcome and one who's had a bad outcome, but who are similar to you in sensibility. And in fact, we learned from our research, speaking with patients, that it was enormously helpful for several men we interviewed who were struggling after receiving the diagnosis of early-stage prostate cancer and choosing among active surveillance, watchful waiting, no intervention versus surgery versus radiation. It was very valuable to them to get a concrete, palpable sense of what life might be like in the future by speaking to other men who had made one of those choices. And we believe that when a patient knows his or her medical mind, they can communicate this to their doctor using the terms we set out today, explaining how and why they weigh risk and benefit in a certain way. And then the doctor can explain his or her own medical mind to the patient. And then together, understanding each other's mindsets, hopefully arrive at the decision that is best for that individual. Thank you.
Beg your pardon. I'm certain everyone enjoyed and learned a great deal, and certainly I did. I'd like to ask you what I tried to make a brief question, but it's complicated. If we cite a paper or commentary in Nature that of the 50 most important preclinical discoveries of the past decade, only 10% could in fact be repeated in another laboratory. Or if we cited the American Society of Clinical Oncology's argument of what was the 50 most important clinical findings in the year 2011, and then we discover that the evidence that supports that was only a fraction as published manuscripts, okay? And the vast majority was an abstract, happened to be presented at ESCO, or an FDA announcement about approval of a drug. My question to you is, how much do we as a profession contribute to the difficulties for patients and for ourselves by not defining what evidence is sufficient?
Well, I'll just add to that. I'll begin by adding to that to say that in terms of guidelines, medical guidelines, that 14% are overturned within 1 year, 23% at 2 years, and by 5 years, almost half. So not only does the evidence change, but also the interpretation and value, how people value the particular evidence changes too. For example, the composition of a committee will change, and all of a sudden the recommendation is overturned. So it's a complex interplay in terms of making guidelines of both evidence and then valuing the evidence.
I agree. And first, that I think is the coda to your question. But I think that we as a profession have a tremendous responsibility to publish and present when studies that are done in good faith turn out not to be even the issue replicated, but have the impact that was initially intended. For example, my laboratory, collaborating with Genentech in San Francisco, and David Ho, who's at the Rockefeller now, collaborating with Biogen, looked at the CD4 structure on the surface of T cells. This is a protein on the surface of T cells. It seemed to be in tissue culture the receptor, the binding, the docking site for HIV. 2 science papers, 2 Nature papers from our lab, similar with him, front of the New York Times, all of this stuff. Then a therapeutic was made, which targeted a soluble receptor, which targeted HIV to be a decoy and bind to the virus. Complete failure. Total failure. Why? Because it turns out that the tissue culture conditions of cell lines and the way viruses were selected generated artifacts. And there are more than one docking sites. In fact, there are several docking sites on the surface of target cells for HIV. And David published and we published the fact that we failed. And it's not a pleasant or comfortable thing to do, especially when your mother called you up and said, "You're on the front of the New York Times." That was the most difficult. But I think that we're wrong sometimes, and it's done in good faith, and it's because often the limitations of the systems and so on. But it is a real issue. And this also actually bothers us to a degree, just to you know, I saw like an angry statement from a policy planner in Washington who said, you know, it takes 15 years for evidence to be implemented in daily clinical practice. And that's an outrage. It shows you how terrible the medical system is. And I thought exactly what you just said, which is 90% of the stuff doesn't get either replicated, or it turns out it's nuanced, or the presentation today, that evidence doesn't apply to the individual.
I really enjoyed your presentation today, and I think a lot about medical decision making. And I wonder, do you think that a maximalist stays a maximalist? Because I'm one of those people who would do the blood pressure medication and the cholesterol, but I always tell everyone that if I had stage 4 cancer, I would go to Hawaii. Like, I would not want certain treatments that other people may want. So do you think that it is stable throughout people's lives, or is it sort of unclear at this point?
So I think that it is not stable throughout people's lives. A very good point, that it's a starting point. It's your initial reaction to things, but then you definitely can change based on experience. You might be a maximalist. We actually refer to Jerry as a maximalist in recovery because of his back, that he's moved a bit away from being a maximalist because of a bad result of proceeding as a maximalist. And the same for the minimalists. You may decide to not take a treatment and have a bad result and maybe change. So I think people do change, and they can change also based on the nature of the problem. It's interesting that you talked about being a maximalist for what would be considered a relatively less urgent or serious issue, and a minimalist for a more serious problem. And typically we think of it the other way, that you would start as a minimalist and change to be a maximalist. So all things are possible, and people move along the spectrum very frequently.
Well, one of the, just briefly, we have a chapter about end of life and the advanced directives and decision making, and we profiled 2 patients. One is a woman, very devout, Irish Catholic believer, who had cancer and had an outstanding and unexpected remission. And she said, I would never be treated again. I do not want to go on a ventilator. I don't want intensive therapies. And then to the absolute shock of her family, when she had a recurrence 8 years later of a cholangiocarcinoma, which is very rare. And she said, I want everything. And why? Because she had found gratification in life from things which seemed mundane. So her daughter, she loved blueberry muffins. Her daughter would give her a blueberry muffin and she'd read to her grandchild. And she wanted to live. And so, Daniel Kahneman actually did a study of your example, not in Michigan, but in Minnesota, of people who said, everything would be great if I just moved to Southern California, because the weather would be beautiful and I'd see the waves. And it's called a focusing illusion, because he looked at the people who stayed in Minneapolis and the ones who went to California, and they had the same level of happiness, because you bring yourself wherever you go.
So I want to.
Oh, I'm sorry.
I want to thank you both for an excellent presentation, and just want to say it certainly echoes and resonates a lot with the work we do in genetics, where in counseling we kind of give both sides of a risk. We might say, someone has a 1% risk that this can happen. That means there's a 99% chance it won't happen, and that's a very central part of our training. And as I was listening to you, though, I was wondering if there's been, because the whole issue of maximalist, minimalist, believer, doubter, this would be an excellent screening tool to have before we even meet with the patient. And I was wondering if there's any efforts just to have to develop something to have patients to fill out in the waiting room. It could be very simple, because I think it could be very helpful in how you actually approach your interaction with the patient.
Well, I think that we've actually been invited to give talks like this one and enjoy from the audience, and a great deal is how do you implement this? How do you make it operational? And I think that the way we came up with these categories from the field research we did was the language. So it's very interesting, because in the early days of psychology, they looked at what adjectives people used to describe themselves. And then they started to think about personality types. It's very interesting. So language is a reflection of mind. So people said to us when we were into, I'm proactive. I want to do everything and more. I want to be ahead of the curve. And the others, as Pam said, to me, less is more. And so I think that this could be developed, but to at least be a starting point. But we found in our own practice that it comes out of the initial conversation. And we're always a little worried about checklists and so on, because there's this tendency to put things in boxes, and people, if they feel pigeonholed from the start or whatever, you don't have an open-ended conversation. So that would be the only, flip side of it. So what I saw a man recently who had an unusual lymphoma called a mantle cell lymphoma, and it's a serious problem, and it's in an evolving set of treatments. And he said, I may go to MD Anderson. I said, well, tell me about yourself. What do you do? I'm an investor. I'm ahead of the curve. I'm proactive, I said, well, you go to MD Anderson, you're going to get a nuclear bomb. That's what it is. You're a maximalist. If you came to Dana-Farber or one of the Harvard hospitals, you'd have a middle. And if you went to Cornell Weill, they have a program doing less is more, where they're looking at so where do you fit in, and why are you thinking this way? And is your approach to investing the wisest approach in terms of your health? So it's a dynamic kind of discussion.
Yeah, we just are worried about, again, sort of boiling it down to the most simple aspects of it and losing the subtlety and the interaction between the clinician and the patient.
Yes. Thank you very much for joining us today in our colloquium. I just wanted to ask a question on the minimalist, maximalist, believer, doubter model. Do you think that in a country, for instance, as in the United Kingdom, where there's a National Health Service, and issues of insured versus uninsured versus co-pays, deductibles versus being insured and possibly becoming uninsured shortly, that there are differences between those two populations in terms of how the perhaps the economic or the resource risk aspect from the individual perceives themselves in the U.S. could perhaps be different because of that influence?
It's an interesting question. I don't think we have any, real data on it.
Are you referring to the fact that basically financial aspects are going to influence where you settle out on this
Yeah,
spectrum?
I mean, if you're in a situation where there is national health insurance, then in that entire population are basically not going to have to factor that in. Is that a purer population if you're trying to understand some of these things that drive preferences compared to someone who is going to have to factor in addition to whether they're a minimalist or a maximalist, how is this going to affect their financial picture from the standpoint of deductibles, copays, and can they afford it to begin with if they don't have it covered as a benefit?
Yeah.
Right.
Yeah. I mean, there was a study not too long ago about addressing the issue of copays, trying to take that out of the picture to see if compliance improved, and in fact it made almost no difference, in my opinion, probably because people had their own idea about whether they really needed this medicine. The maximalists wanted to take it and the minimalists didn't, and the copay was a small but not a major issue.
I also just impressionistically Canada, because there are a number of Canadians we know, and I've talked to both physicians and also patients, and there the system may be a little more flexible than it is in Britain, but certainly the mindset seemed to be there. Now, whether people feel more constrained in it, there's the Harley Street doctors in London who are, you can go outside National Health Service and maybe they get the maximalists, but I think, as Pam said, the only data that, in terms of the United States, that money made no difference in terms of people wanted to take hypertension medications, statins, and so on.
Thank you. I'm glad to have had the opportunity to see your presentation and read your book. I'm intrigued by your advocacy and use of stories in talking about helping people to make these types of decisions and the use of narrative as a way of framing the challenge of helping people to imagine the things that they cannot imagine because they've never actually experienced those conditions. I wonder, however, if you could comment a little bit about the challenges in finding the right stories, the right people to be talking to guide decisions. And many of the examples you brought up were treatment contexts, person who had surgery, person who didn't have surgery, et cetera. I have been particularly thinking recently about preventive contexts, for example, vaccination, where some stories are very easy to find. I mean, you'll go online, you can find plenty of people with stories who believe, rightly or wrongly, that vaccines may have caused negative health effects. Finding the stories of prevention is much harder. And so I'm wondering if you could talk about how we can use stories in this type of context to deal with those kinds of preventive contexts, where what we're really trying to do is help people to imagine not having something happen.
Right. Well, I think it's a very good point. I mean, first, in terms of learning, Howard Gardner, who's at Harvard, who studied education, points out there are three ways people get information. One is numbers, the other's graphs, and the third is stories. And what makes the most impact and is sustained in our thinking are stories. We live by stories. We grow up with stories. And it's tricky, as you say, because if you go on the internet, it's the Wild West. You have every crazy testimonial in the world, including autism and this and that, even though it's been disproved, and the guy in England was shown to be a charlatan and making up the data and so on. The problem, it reminds me of this, the absence of evidence is not evidence. So if you say, look at me, I had a colonoscopy and I don't have colon cancer, that's not impressive. So what you probably need, are stories where someone said, I just didn't want to have a colonoscopy. It seemed annoying. I didn't believe in it. No one in my family had colon cancer. It seemed irrelevant. It's annoying. I don't want to have to take that terrible prep and be on the toilet for 12 hours. And now I have colon cancer. And, you know, in terms of prevention, you know, you know, part of the numbers in the debate in terms of prostate and mammogram, and, you know, most people don't have a problem when they're screened. And yet, when you are the one, you know, who potentially, whose life can be saved, or whose life was not saved, you know, the problem also is that the minimalist doubters now come up with, and the data are really fuzzy. Well, you know, a lot of breast cancers grow slowly so that if you find it later, you can still have surgery, chemo, and radiation, and you won't die. All right? But having spent a career giving people, you know, radiation and chemotherapy, I'd rather have a simple excisional biopsy than take the risk. So, you know, there's a pushback, too, in terms of prevention. Right now, prevention is, you know, for a while it was in ascendancy. Now it's kind of being challenged. But I think stories of people whose lives might have been saved or improved if they had been prudent about prevention could be a way to go.
So one of the things that I really liked about your book, and that I also really liked about your talk, is that you don't ever pass judgment on maximizers versus minimizers, and it seems as though you're really treating this as a legitimate preference that could potentially be guiding people's decisions and helping them know what's best for them.
That's how we stayed married.
Exactly. So, of course, that leaves me to wonder whether or not there actually are advantages for being a maximizer or a minimizer. Are there outcomes that could potentially be better if you decide chronically in one way or the other? And following up on that, if you are extreme in either of these traits, could that be potentially a negative thing for you in terms of your health outcomes?
Well, you know that, you know, based on the data regarding heart attacks, that you will reduce your risk of heart attack by 30% by taking the statin. So the maximalist will have a will have a reduced risk of heart attack, let's say, because these are non-fatal heart attacks, by some small amount. And now you have to balance that against the cost of taking the medication, the side effects of taking the medication, and any sort of
Emotional.
Yes, emotional aspects that you are taking this medicine that you don't want to take if you're a minimalist on your quality of life. And so how you balance that, I mean, the experiment has been done with regard to the thing that you can measure, which is heart attacks. The other things are harder to measure. So, you know, if you want to know if there's a survival advantage, then it becomes a little bit more complicated because, as you say, some maximalists will go on to have treatments that perhaps do not give a survival advantage. So, you know, moderation is a good thing.
I think it's very complicated, you know, from an individual point of view. You know, certainly when Pam said I'm a maximalist in recovery, you can't. I mean, you can't imagine how many people call me for advice about back pain, and I'm not an orthopedic surgeon or, you know, physiatrist or anything. But boy, do I give them advice about back pain, which is don't have surgery. You know, which has gone to the opposite end. But sometimes, you know, people decide I'm going to have surgery, I'm going to have the risk because it more quickly alleviates the pain and so on. And so I think that what's interesting, and as Pam said, is that a lot of this involves a dimension that is not amenable to measuring in terms of outcomes the way we usually think of outcomes, which is a concrete physical dimension of the experience of illness.
It leads into the subject of regret, which we talk about in the book. And we do have a chapter in there where we discuss two patients who had surgery, both with bad outcomes. One was disappointed, but no regret. In other words, didn't feel that he had done the wrong thing. And the other patient, a woman who had foot surgery, felt this huge burden that she regretted her decision forever, basically. And the way they came to the decision and whether it was in concert with their mindset made a huge difference. And how do you really measure that?
A wonderful presentation and book, and prior books too. I was delighted to hear you talk about the, not using sort of the checklist approach to the different mindsets, because I struggled to answer your questions at the beginning about hypertension. I'm an internist, and so I know well the benefits of taking antihypertensives, but I'm also sort of a, don't take drugs unless you have to person. So, I had a hard time answering those questions, and I think the spectrum is a more realistic sort of, and change, and situation and context. So it's not dichotomized in a very clear way for everybody all the time. So I think that's, I was delighted to hear you talk more about the conversation being the important way of doing that as a doctor. So I have a question for you, though, and this is based on the fact that most of my uninsured patients are minimalists for a reason. Mm-hmm. And one of the things that I work on is studying both empirically and kind of philosophically, if you will, physician stewardship. That is, how can we be good stewards of limited pooled social resources? And I struggle at times with maximalist patients in that regard, or the technology-focused patients who think that as long as they get a total body CAT scan, then they'll be proven to be healthy. So I wonder if you could comment on the implications of these mindsets and stuff for the practice of stewardship.
Okay, I think that you don't want people to do wild and wasteful things, and that's stewardship and it of course depends on the severity of the problem and all the rest. And I think that if using the language or the terms to say, I understand your mindset, I understand how you are thinking and approaching this, and let me make sure I do. You want to be proactive, you want to be ahead of the curve, you're a maximalist, you do everything. But in this case, doing a total body CAT scan is not at all likely to give you what you want, okay? And then you can do the typical doctor's trick, which is to say, if you want to be a maximalist, have the healthiest diet you can possibly have, and exercise regularly, and, set some time to de-stress yourself, because most maximalists are hyper type A, all of this kind of stuff. And sort of work with the person on that level. Now, also, a physician is not obligated to do everything that a patient demands. I mean, this is, and it doesn't mean that it has to be. And in fact, in the beginning of the book, one of the internists we profile, Jacques Carter, we show he has 3 patients, each with a different mindset. One of whom is Michelle Bird, is this maximalist. Her blood pressure, she wants her blood pressure to never be above 115 systolic. And even though she's had side effects from the medicine. And so he says, which I think is a wonderful term, that a lot of his practice is negotiation. And he said, I'm negotiating with her, but he's not writing a prescription. And she sticks with him as her doctor because she knows that he's listening, he's respectful, but he's not a rubber stamp. And so it's a challenge. On the other hand, my also concern is in terms of the evidence and the discussion we had before. So the American College of Physicians came out with the, choose wisely and all of that. Don't do a routine EKG. A week later, JAMA had an article which was pretty convincing, showing that in older people, Medicare patients, routine EKGs were enormously informative about cardiovascular risk in the future and could stratify patients between those who actually you would more encourage to have, say, statins at the age of 65 or 70 versus those not. So I think we also have to be very careful about this one-size-fits-all. That it's we're doing too much, less is more, and don't do tests, and yet, there's a gray zone.
And just to add to that, in terms of cost, I'll give you another vignette. A patient of mine was convinced that she had heart problem, a young patient. She would come in, call up, need to be seen all the time, go to the emergency room all the time. And finally, we had a real heart-to-heart talk about this, as it were. And she said to me, what I really want is an echocardiogram. And I said, well, you've had a lot of tests. I don't think there's anything wrong with your heart. And I said, but if you had that and it was normal, would you feel a lot better? She said, yes, I would. So we did it. It was normal. 2 years later, no ER visits, no visits to the office. So was that a waste of money, or was it not, to the medical system?
I appreciate the perspective of finding out where the patient's coming from, maximalist or minimalist, related to their care and their goals of care and treatments. And as a clinician, I find I'm struggling more and more, especially, let's say, on an inpatient service with constraints, with time spent with patients, less and less time. There's other constraints, financial, whether we like it or not, and other demands. And I'm meeting people for the first time, and unfortunately meeting them oftentimes at the end stages of their disease process, and very much would like to find out and need to elicit, what their perspectives are. And I was wondering if you could elaborate a little bit more on how you handle that situation when you really don't have a rapport with a person, but and very perhaps limited time, how you can use some of your techniques to get at really what you think the patient, the patient perspectives would be.
I think that's one of the hardest things, especially now with the change towards having hospitalist care for patients in the hospital. You're often meeting a patient for the first time who's very ill and you don't know them. And so difficult on both sides for you and for the patient to deal with these type of issues that require what we often think as long-term discussion and input. So the one thing we can say is that this language may be helpful if you start with that type of language, that you can pretty immediately get a feel for what's going on in the patient or from their family. That could help with those decisions, but there's no substitute, of course, for actually knowing somebody in depth.
And just to echo, I think that this idea that everything in medicine has to conform to efficiency. There are things that we do that are, quote, not efficient in terms of an economic model, which is to get a product out in the shortest period of time. It takes time, especially when people are making end-of-life decisions. And especially when, 2 of the 3 children don't agree with the third or with their mother or whatever. And it's very disheartening, to be frank, that so much of the emotional and psychological dimension of medicine, which as you get older and you've cared for patients, the actual clinical information is largely mastered. And so a lot of the gratification of caring for people has to do with that emotional interplay, and it calls upon you as an individual to extend yourself to that person. None of that is really accounted for in terms of the reconfiguring of the system. There's a lot of lip service given to patient-centered care and humanism and values and preferences. There's a lot of lip service. Okay, but there was a fascinating perspective in the New England Journal of Medicine a few weeks ago. There has not been a single quality measure from Medicare in the last decade that is preference responsive. Not one. And it's just outrageous. So that's my soapbox. Thank you very much.